I'm going to be talking about AWR anatomy, as all of you guys know, and I like to call it the Hitchhiker's Guide to AWR anatomy, because at the end of the day, it's something that we have all been getting more intimately aware of over the past few years, and it's a gradual learning process. If you make someone sit down and just listen to this lecture and expect them to be uh, uh, to have a complete idea as to what's really going on in the abdominal wall, I think that's being a little over enthusiastic or over optimistic. But this can serve as a nice guideline. So the next time you step into the OR, or you land up watching one of the amazing Zoom lectures that are being propagated over the past few weeks, specifically talking about AWR procedures, it'll help you correlate more as to what exactly is going on. That's my intention of the talk. These are my disclosures. They're not really relevant to what we're talking about today. This is a more pertinent disclosure. Over the past couple of years, I have actually been doing a lot of open AWR. Because I work at Sir JJ Hospital, which is a tertiary referral center, we do get a lot of cases with crazy complex ventral hernias. And they usually land up requiring some form of open repair with an abdominoplasty, paniculectomy, ab wall debridement, or whatnot. So that's a huge bulk of my practice. Over the past couple of years, I have also gradually been transitioning towards ETEP and trying to cut my teeth with it. As a result of which, my IPOM practice has been going down. And since we are a teaching center, these procedures are also being performed more by guys who've just graduated and people who are still in their residencies. The reason I'm sharing all of these details with you is that because I do a lot of open procedures, I am very, very comfortable with what's happening within the abdominal wall with regards to the fascia, the muscles, the various tendinous aponeurosis. And that gives me a lot of confidence going forward and speaking to you about this important topic. Before we begin, just wipe your mind clean. Forget anything you think you know of the abdominal wall, and this will be easy to follow. Forget all of these diagrams that have been shoved down our throats ever since our first year of med school. We'll start absolutely afresh. The talk, by and large, is going to be divided into these parts. We'll talk about lines, then we'll discuss spaces, and then finally, I'll talk to you about the surgical technique, which is the primary endpoint of this talk, right? So let's start with lines. The linea alba is a tendinous insertion that exists in the midline, and it's a tendinous insertion of all of the three oblique muscles. That's the external oblique, the internal oblique, and the transversus abdominis. It's flanked by the rectus abdominis, but as such, apart from being bounded by it, it doesn't have any origin or insertion of the rectus by itself. Remember, God has given you a very stable spine at the posterior part of the trunk. He's also given you a very stable tendinous anterior part of your trunk, which is the linea alba, mirroring the spine. So your entire trunk is stabilized. Cutting open the linea alba is akin to tendon injury. And think about that. We take so much care repairing tendons in the hands and the legs whenever we have all of these trauma cases coming in. But we don't give a second thought to dividing this midline tendon when we're doing a laparotomy. And a lot of times, unfortunately, we don't give it a lot of thought suturing it back together as well. And that's the cause of a lot of incisional hernias. The semilunar line is lateral to the rectus abdominis muscle, and it is usually considered the medial most extent of the three obliques. And then finally, you have the arcuate line, or the line of Douglas, which exists about 3 to 4 centimeters below the level of the umbilicus. This is the inferior most extent of the post rectus sheath. The PRS is deficient below the arcuate line. We'll talk about that as we go ahead. Now, we'll talk about the ab wall with these cross sections. If you take a cross section really high up at the costal margin, you'll see that the rectus abdominis muscle is directly resting on the costal cartilage. There's no post rectus sheath over here. The anterectus sheath is on top. If you go ahead and take a cross section at the midpoint of the abdomen somewhere, you'll realize the cross section is looking quite similar to what our usual understanding of the abdominal wall is. So the external oblique gives off a slip that contributes to the anterectus sheath. The internal oblique splits into an anterior and a posterior lamina and goes to the anterior and posterior sheaths. And the transversus abdominis gives off one aponeurosis that contributes to the post rectus sheath. The PRS and these oblique muscles are resting on the transversalis fascia and the peritoneum right there. Now, if you take a cross section below this level, which is the arcuate line, you'll see that suddenly the aponeurosis of all of the three anterolateral muscles are now contributing to the anterior rectus sheath, and there's nothing going on in the posterior aspect of the rectus abdominis. This entire complex is resting directly onto the transversalis fascia and the peritoneum. This is also going to be containing some amount of preperitoneal fat, but we don't have a posterior fascia in its true sense over here. It's just the peritoneum. If you go ahead and see what's happening with the rectus abdominis in this dissected specimen, you'll see that the deep superior epigastric arteries and the inferior deep epigastric arteries all kind of go behind or deep to the rectus abdominis, and they have this sort of anastomosis or intermingling in this area. The anatomy textbooks will tell you the dominant supply to the rectus abdominis is actually from the inferior epigastrics, and the superior epigastrics just play a sort of supportive role. And the other thing that you can notice here is the postrectus sheath is deficient a few centimeters below the level of the umbilicus. Coming back to this diagram, appreciate that the external oblique muscle is arising superficial to the costal cartilage. The internal oblique muscle, which has been cut away over here, exists between the iliac crest and the costal cartilage itself. So the external oblique is superficial to the costal cartilage, the internal oblique comes at the costal margin, and the transversus abdominis, which is the muscle that can be seen over here, takes its origin from inside the costal cartilage or the chest wall. The transversus abdominis muscle has transverse fibers, as is apparent, and these muscles, their basal tone leads to a corset-like action all across the abdominal wall, and that significantly contributes to a rise in intra-abdominal pressure when this muscle is activated. Like all muscles, there's going to be a muscular belly, and there's going to be an aponeurotic section. Now, look at this junction between the muscle and the aponeurotic junction. It kind of disappears behind the rectus abdominis, right? And if you see on this side, the rectus has completely been taken off. The same muscular aponeurotic junction goes towards the xiphoid. Now, this actually doesn't make sense because we have all been told that all of the three anterolateral muscles end at the semilunar line, but you can clearly see that the transversus abdominis is extending medial to the line in the uppermost part of the abdomen. This is the first major misconception that all of us have that needs to be broken. If you have a look at cross-section anatomy, going right from T12 to L5, and if you draw a line at the medial most extent of the transversus abdominis, you'll see high up in the epigastrium, the transversus goes medial to the semilunar line and exists behind the rectus abdominis. And this is that transition line that I was speaking to you guys about. As you move downwards, this line moves further laterally. And then finally around the L3, L4, L5 region, we get this sort of configuration where all of the three lateral muscles are lateral to the semilunar line. Now, interestingly, remember, the muscle becomes lateralized, but the aponeurosis is still there. And it is this aponeurosis that we'll end up exploiting in our transversus abdominis release, and we're going to be talking about a little later. If you look at the abdomen head on, this is what the TA looks like. So the external and the internal oblique have both been cut off. You can appreciate the transverse orientation of the fibers, and just in the paramedian location is the aponeurotic section of the transversus abdominis. If you just see the junction between the muscle and the aponeurosis and join these two lines, it almost forms a namaste, right? And the tip of this namaste is actually meeting in the epigastrium. And if I superimpose where the rectus abdominis muscles will be, you'll see that in the epigastrium, there is this massive amount of transversus belly, which means that the transversus abdominis is easy to identify. As you move downwards, this entire area becomes more aponeurotic, and it may be difficult to get into the right plane. So I am going to be covering TAR a little later, but just to hammer home the point right now, the TAR classically starts in the epigastrium because the transversus is just calling out to be divided in the epigastrium. Below, it's a little shy and it kind of hides away. Now let's move on to spaces. We have the two rectus abdominis muscles on either side, which are being divided in the midline by the linea alba, which is a tendinous insertion of the three flank muscles. Now, logic will tell you that wherever there's peritoneum in the abdomen, there should be a preperitoneal space, right? But honestly, uh, the preperitoneal space is ample enough and opens up easily enough only in the areas that I've highlighted right now in green. So this inverted triangle high up is the falciform ligament. And below the level of the umbilicus, this is the pelvic preperitoneal area. This is the area where we do all of our inguinal repairs, our TEPs, ETPs, and TAPPs. So you'll realize that a lot of times when you attempt a preperitoneal repair just in the paramedian location or sometimes in the flank, you'll end up with a lot of buttonholing of the peritoneum. That space doesn't open up as easily, but if you're doing it in the vicinity of the falciform or in the pelvic preperitoneal area, it opens up just perfectly. Now, logic will tell you that wherever there's transversalis fascia, there should be a pretransversalis plane, right? You're kind of correct, but it's only in the vicinity of the semilunar line and lateral to it that this plane is actually easy to open up in surgery. So the transversalis, the pretransversalis plane actually does exist in the median and paramedian locations, but it's only in the lateral areas that the plane is ample and easy to open. If you look at the anterior abdominal wall from the posterior aspect, this is what it will look like. You have the two rectus abdominis muscles, so therefore there's a retrorectus space. You have the falciform up top. Lower down, you have the pelvic preperitoneal area. So way lower down, you can see this is the bladder and this will be the cave of Ferencius right now. And you can see the inferior epigastrics are on either side of the space. What exists as a preperitoneal space lateral to the inferior epigastrics? Well, it's a space of Bogros. As you can see in this diagram, the Bogros space actually extends all the way up to the diaphragm. It's not easy to open up that high up, but it does exist. And what is straddling the paramedian preperitoneal space and the Bogros space is the inferior epigastric vessels right here. And if you look at an actual cross section in the area, the pelvic preperitoneal space kind of looks like a dumbbell. You have the cave of Retzius between the pubis and the urinary bladder. You have the inferior epigastrics on either side, and you have a Bogros space that exists just beyond it. While there is no absolute anatomical ligament which is holding the fascia together in the vicinity of the inferior epigastrics, those who do inguinal repairs will know that the planes over here are just a little sticky. It takes some effort to go from the cave of Retzius into the lateral space. And remember, we do this keeping the inferior epigastrics up to the roof. There has been some literature that's been coming up saying that there is an actual facial band here, but I would refrain from using anything which is not mainstream. So it's a dumbbell shaped space which opens up on either side, and the marker of differentiation between the two areas is the deep inferior epigastric vessel. The next part of the talk is about technique, because what's the point of learning about these lines and spaces if you can't learn to use them to your advantage, right? First and foremost, let's get to TEP inguinals and ETP inguinals. Those of you who do TEPs, this is usually going to be the port arrangement. You have a camera port, which is below the level of the umbilicus and slightly offset to one side. And most people end up using midline or paramidline ports, the two working ports. And the sort of view that you have is a little restricted. Now, there is a saying, sometimes you can be standing so close to the tree that you lose sight of the forest. And in a short patient with a short pubo-umbilical distance, that's the space that extends between the umbilicus and the pubic symphysis, you can find this area very claustrophobic when you're operating. And that causes a lot of discomfort. It is going to create a problem with space creation. When you have a peritoneal hole, it's difficult to manage that. And dissection in general proceeds a little slowly in these cases. Now, there was one man who wasn't happy with this arrangement, and his name is Professor Jorge Diaz. He had a brilliant idea, and he said, if I can't see the forest because of this tree, why don't I just stand a little distance away from this tree? And he did the simplest of things. He moved his camera port a little higher up, about an inch and a half to 2 inches above the level of the umbilicus. And this port now resides in the retrorectus space. Now, because your camera port has moved back, you have a more panoramic view of the entire inguinal region, and you can use this to your advantage. Those midline ports that are so cumbersome sometimes, well, now you can triangulate them, and these are comfortable ports that can help you operate. You can not only do unilateral hernias very easily, but bilateral hernias are performed very quickly using the ETP approach. Now, remember this diagram that I spoke to you about? We have the retractor spaces on either side, then you have this preperitoneal space in two triangles, and you have the pretransversalis plane laterally. We have to find a way to connect these spaces together, because if we don't, we are not going to have a single large expanse to put any of our meshes in. And that's what hernia repair is all about, right? It's not going to be a durable or robust repair unless you're putting in some form of reinforcement. So it seems like a puzzle that somehow landed up challenging a lot of people over the years until this man came along. He said, I can do this entire thing in a minimally invasive fashion, and he had a wonderful idea as to how to achieve that. It seemed like all of the pieces of the puzzle aligned for him, and he was able to come to the conclusion that the main issue with a minimally invasive restopa or retromuscular repair is getting across the linea alba. Remember, the retrorectus spaces are separated in the midline by this tendinous structure. When we perform any open surgery, you'll end up dividing the linea alba, and during the hernia repair, you can easily gain access to the retrorectus spaces of either side. But when you're doing a minimally invasive repair, it seems counterintuitive to divide the linea alba just to connect these two spaces. Now, his idea was to go behind the linea alba from one retrorectus space to the other, utilizing that preperitoneal fat in the midline that I showed you guys. So you can see we have the costal cartilage here. So this is way high up in the epigastrium, and the fat where the arrow resides is actually the falciform ligament. The falciform's external surface has a serosal layer to it, which is the peritoneum, but the falciform itself consists of preperitoneal fat. And if you manage to stay within this fat, you can have an entirely extraperitoneal repair. Let's see how this happens. The connection of one retrorectus space to the other is termed a crossover, and there are two types. There's a superior and an inferior crossover. We'll be discussing the superior crossover technique first. The aim is to dissect the retrorectus space on one side entirely. How do you do this? You put in a blunt cannula into the retrorectus space. You can either with the help of a PDP balloon or bluntly with the help of a scope dissect this entire space out, or as much as possible. You then gain access into the epigastric preperitoneal area, which is the substance of the falciform. Now you can see here, because there is an overlap between these two areas, you can cross from one space to the other without ever breaching the peritoneum. Well, in an ideal world at least. Then you can exploit the overlap on the contralateral side to gain access into the contralateral retrorectus space. And suddenly you have these two spaces connected to each other across the midline, and your dissection can proceed further. This may seem a little confusing because the image is head on, but gets way easier when you have cross-sectional anatomy shown to you. Now you can see here, I have one rectus abdominis, another rectus abdominis, the three flanks. This is the external oblique, the internal, and the transversus abdominis. And this triangular blob of fat is the falciform ligament. You know for a fact that we are in the epigastrium and not lower down, because just have a look at the transversus abdominis. This is like medial. There is quite a bit of overlap between the rectus abdominis and the transversus over here. So we are definitely not lower down in the abdomen. What's the first step? The first step is getting into one of the retrorectus spaces. For a right-handed surgeon, this is the left side just because it's more ergonomic. Now, under CO2 insufflation, the entire space opens up. See what happens to the post-rectus sheath medially. It becomes almost vertical, like a wall. And this makes it very easy to identify it higher and to divide it. Once you've divided the post-rectus sheath, you go into the midline preperitoneal space, and you get into the substance of the falciform. You shave the falciform off the midline, and you go to the contralateral side and you shave the fat off the contralateral post-rectus sheath, which is shown here in red. You divide that post-rectus sheath, and now suddenly these two spaces can be connected. As you move from the epigastrium down in caudally, the amount of preperitoneal fat becomes more scarce. So you're going to have to dissect the space out and try to salvage as much of the fat and peritoneum as possible, else you'll have a big hole in the posterior fascia to suture up a little later. As you move down towards the level of the umbilicus, sometimes there is no fat. This is the actual preperitoneal space, and you'll be shaving bare peritoneum off the linea alba. And I'll tell you from experience, this can get challenging. And more often than not, especially in a thin patient or in the vicinity of the hernia, you'll end up with this. You land up making a hole in the posterior fascia and you have pneumoperitoneum. Your space doesn't collapse because you already dissected the interparietal space right now, but it does create a posterior defect that you need to suture. Because remember, if you're putting in an uncoated polypropylene mesh in the retrorectus space, you don't want this hole to be open. You'll have viscera coming into contact with proline, and we all know what sort of adverse outcomes we can get with that. So you have to suture this. You can do this with PDS, or you can do this with any sort of barbed sutures. Uh, the inferior crossover is a little easier, but I would say in certain patients can get ergonomically challenging because you're in between the legs of the patient. And in a hefty patient, it can be a little difficult. The first part of the dissection stays the same. You'll end up dissecting one of the retrorectus spaces. Your port is a little higher up, and you gain access into the pelvic preperitoneal space. This is the cave of Retzius. This is the inguinal space that we are all so familiar with. And using this overlap, you put in 3 extra ports into the pelvis. The middle one is a camera port. You have 2 working ports on either side. And using these now inferior ports, you can gain access into the contralateral retrorectus space. In cross section, this is what it actually lands up looking like. When you are down in the pelvis, in the pelvic preperitoneal space right here, there's insufflation here. What you're going to be looking at cranially is the arcuate line. And you're going to use some form of energy to divide the medial edges of the arcuate line without damaging the linea alba. So once you divide the arcuate lines on both sides, you have access into the retrorectus spaces, and dissection can now proceed in this area. All right, so before we go on to the next part of the talk, I'd like to tell you a little bit about the neurovascular anatomy of the abdominal wall. I won't bore you with origins, insertions of the muscles, and what the exact trajectory of all of these nerves and vessels are, but I'll leave you with one important fact. All of the neurovascular supply of the abdominal wall comes from the lateral aspect, and it all rests on the transversus abdominis. You can see here the internal and the external have been taken away. The veins, the nerves, and the arteries all lie between the transversus and the internal oblique. That is the neurovascular plane of the abdomen. Uh, I'm not being completely honest here because the abdominal wall does receive significant supply from the superior and inferior deep epigastrics, as you can see right here and here. But remember, the nerves all come into the abdominal wall from a lateral aspect. And in cross section, this is kind of what it looks like. The external oblique, the internal, the transversus, you can see this is quite medial. There's an overlap with the rectus abdominis. All of the neurovascular supply that's coming in laterally pierces the posterior lamina of internal oblique, comes to lie in the retrorectus space. It supplies the rectus abdominis muscle to various degrees, and then it continues epiphyseally to supply the skin at the midline. And it is these perforating vessels that we'll end up dividing when we do an onlay repair for a primary ventral hernia, devascularizing all of the skin flaps that we've created, and then having all of the sequelae like SSIs and skin necrosis and whatnot. If you divide this structure medial the rectus abdominis, you have a risk of denervating the rectus abdominis, and that is counterintuitive. Remember, the entire purpose of doing a ventral hernia repair is to get this abdominal wall as close to normal as possible, which means that not only does it anatomically have to be as normal as possible, functionally it has to be as normal as possible as well. The rectus abdominis is the major flexor of the trunk. So when we denervate the rectus abdominis, we will end up with a lot of problems in the post-op period. Patients can come back with bulges, with weakness, with odd complaints that unfortunately have a chance of never going away because we have severed or damaged these nerves. When we talk about the classic Reeve-Stopa repair, this is what we're talking about. The repair is restricted between the semilunar lines of either side. So you place a mesh. The mesh is only as wide as the sum of the retrorectus spaces. You can't go beyond that. This repair is amazing for small to moderately sized hernias, and is very, very robust. But what if I told you the hernia was a little larger? Now, not only are you going to find it difficult to close this defect, but suddenly the amount of mesh overlap that you have laterally seems very, very inadequate. And this is going to be the cause of a recurrence down the line. This seemed to be a conundrum that a lot of people were facing. So Carbonell in, I believe, 2007 or 2008, gave his Carbonell repair. And what he essentially did was he divided the posterior lamina of internal oblique and he entered the space between the transversus and the internal oblique laterally. So he was able to dissect a space out beyond the semilunar line, but logic will tell you that going in and putting in a mesh in the neurovascular plane of the abdominal wall is not, uh, or rather, does not seem very natural. It seems to go against surgical principles. Not only that, when you land up dividing this posterictus sheath, the posterior lamina of internal oblique over here, you can land up severing the neurovascular bundles that I discussed earlier. So you're denervating the abdominal wall and having all of those problems that we spoke about just right now. As you can imagine, that repair did not get any widespread adoption or acceptability, but the problem still persisted. And it took this man, Yuri Novitsky, to figure out a brilliant way of actually circumventing this problem. Novitsky's entire surgery is based on identifying that the transversus abdominis does not end at the semilunar line, but it extends medial to the semilunar line, right behind the rectus abdominis. Therefore, this area medial to the neurovascular bundles, that's where this muscle is just calling out to be exploited, to be divided. Let's see how that actually happens in action. The first part of the surgery is like any retrorectus repair. You divide the posterectus sheath medially and you gain access into the retrorectus space that's behind them, between the muscle here and the posterectus sheath here. Remember to stop dissecting once you see the neurovascular structures, and I would highly, highly advise not to use any cautery in this area. If you'll end up using only blunt dissection, imagine a peanut on a hemostat. You cannot go through fascia. You may be damaging some blood vessels here and there, you may be causing some ooze, or you may be going into muscle, but remember, you can't divide fascia in a blunt fashion. Whereas if you use a cautery tip in this area, you can land up going through any of this fascia over here. You can have lateral thermal injury that damages the neurovascular bundles and then land up in trouble. Once you have finished off the dissection up to the neurovascular bundles, there are about 5 or 6 of these along the length of the abdominal wall. What will be seen to you at the lateral part of the retrorectus space is the posterior lamina of the internal oblique. And it's just about dividing it. In the epigastrium, you are actually able to see the transversus fibers deep to this fascia. This division happens medial to the neurovascular bundles. You do not impinge upon them. You try to stay at least a centimeter to centimeter and a half away. Once you've divided the posterior lamina of internal oblique, things become much easier. You can see the belly of the transversus abdominis. It's calling out to be divided. And suddenly, with just a small amount of division, you have taken away the medial insertion of the transversus abdominis. And magic, you've left the neurovascular bundles intact. What this also lets you do is get into the lateral pretransversalis plane, as you can see by this arrow right now. Once you've divided the transversus and you start dissecting this plane, you'll see myofascial medialization. How much medialization do you get? Well, for the anterior fascia, which is the anterectus sheath, the rectus abdominis, and all of these muscles, you get a medialization of up to 10 centimeters on one side in an adult. There's a wonderful paper by Majumdar and Novitsky's group from a couple of years back. They did a study in cadavers. People who perform the TAW will tell you the amount of medialization that you achieve for the posterior fascia is way, way higher. This is extremely elastic because it contains only the transversalis fascia and the peritoneum over here, whereas the anterior complex has all of the anterolateral muscles and the rectus abdominis, so it's a little less stretchy. But we have seen in a bunch of papers coming forward that posterior component separation gives you as much, or at least almost as much, medialization of the fascia compared to anterior component separation. Now, when you've done the TAR and you've gotten into this lateral pretransversalis or preperitoneal plane, you've suddenly found this magic way of combining all of these spaces together, right? This entire plane extends from the central tendon of diaphragm up top. It goes down into the cave of Retzius below, and you actually go psoas to psoas posterolaterally. This is what giant prosthetic reinforcement of the visceral sac is all about. You're able to put in a large uncoated prosthesis, and because it's in the interparietal plane, it's mechanically robust because it's a sublay mesh, and because it's just adjacent to a vascular muscle, there's a smaller chance of surgical site infections. And when infections do occur, the body manages to clear it off a whole lot better when compared to perhaps an onlay repair. The added advantage of component separation obviously is being able to tackle bigger and larger hernias. And you're able to close larger defects, thereby getting the abdominal wall back to as close to normal as possible. The medialization of rectus abdominis, we have been shown time and time again, does a lot to improve the quality of life of patients going forward. And we should try as much as possible to avoid bridging repairs. And AWR is essentially a step in that direction, reconstruction of the abdominal wall. Thank you so much, guys. Okay, some comments, questions?
Yeah, first, Eham, wonderful
Thank you so much.
presentation. Yeah, I'll have a point to make.
Yeah.
Most surgeons around the world would like to close the PRS when they are doing a ETP TAR, or they'd like to close the peritoneum first.
Yeah.
That's my first point. And to continue, a few surgeons I know, they always do a unilateral TAR so as to avoid any tension on the PRS while they are closing. They'll always do a ETP right stopper, but invariably they'll do a TAR on one side so as to have absolutely no pressure on the PRS. What's your comment on that?
Okay, I'll take the ETEP question first and hope not to embarrass myself since Dr. Amanna is on the group right now. So when you're doing an ETEP, retromuscular repair, because you're doing it under insufflation, invariably there's going to be more amount of tension on the posterior closure. And this is obviously at a chance of dehiscence after the surgery. So what you'll end up with is not a true recurrence because the anterior fascia is intact. You'll end up with a posterior recurrence. The bowel or any other visceral contents for that matter can go into the dissected retrorectus space, and you can land up with obstruction, strangulation. You will end up with bowel, which may not be symptomatic right now, but it is in contact with uncoated polypropylene meshes, and you have all of the sequelae of that: really bad adhesions, delayed obstruction as a result of fibrotic bands, and of course AC fistulas. So people adding a TAR unilaterally in ETEP reef-stopa, I think, is a fact. It is a sensible thing going forwards because one, you're able to give the patient a minimally invasive procedure, and this is about like moderately sized hernias. I'm talking about 7, 8, 9 centimeter type hernias which are getting closed, maybe in a smaller patient around 5 or 6. It's better to do a TAR on one side and have a safe surgery than to avoid TAR, fearing some unknown sequelae that people have yet not quantified and people are unable to describe when they talk about friction against adding a TAR to this. That's a better option than not doing anything at all and landing up with a complex recurrence, which is a pain to take care of. And it's also difficult to detect. I have had one in my ETEP series, and that got detected because I have a very low threshold for scanning these patients. The patient was completely asymptomatic, scanned her posterior dehiscence, went in, took care of the entire thing, did an IPOM, and came out. But ETP has a very different complication profile compared to the other ventral hernia repairs that we have, the MIS one. So it makes sense that the principles of the procedure will also slightly change. You may have to do a little bit more compared to an open procedure when you are completely in control of the dissection and you're not suturing under insufflation, that is stretching all of your fascia apart. I'm sorry, what is your first question?
The first part was what percentage of surgeons would actually close the PRS and would not just close the peritoneal defects?
Okay, so I'm going to show you that slide once again because you raised a very important point. And this begs, being repeated. All right. So if we look at this slide over here, this entire space in the middle, This is the median or the midline preperitoneal space. Dissecting this space, I would say, is the single most important step, even more than the crossover when you're doing an ETA brief stopa, because if you salvage this peritoneum and fat over here, it's going to save you the headache of having a huge posterior defect. It's going to save you the headache of perhaps adding a tar to close the posterior defect. It just requires about 15 to 20 minutes of extra dissection, being meticulous, not damaging the linea alba in this area. So the important thing is, say I managed to do the entire surgery without having a single posterior hole. All right. Hypothetically, I had an amazing day. I was absolutely on point. Surgery was fabulous. This usually happens for a small primary ventral hernia. For an incisional hernia, it's never going to be that simple. But you can land up with a posterior wall that looks somewhat like this along the entire length of the abdominal wall with peritoneum and preperitoneal fat in the midline. My question is, this is already going to serve as a barrier between the mesh and the viscera. The posterior sheath is not a load-bearing structure anymore in the abdominal wall because we have landed up dividing it. So if I try to stretch the PRS from here to here, I am actually trying to stretch it beyond what its normal insertion was. Remember, the linea alba is in the middle. So that's 1.5 centimeters and 2 centimeters where there was no PRS. So now suddenly I'm stretching the PRS on both sides, trying to close it. You can invariably damage the posterior complex and you're putting these sutures under significant tension. So I think these sort of patients where we are pushing ourselves to close the PRS and not being sufficiently happy with the peritoneum and the preperitoneal fat, we are inviting trouble in the near post-op course. And there is there are these few diagrams by Reeves himself from the 1970s, a bunch of French papers that I have lying around somewhere on my laptop. But even in his cases, in the initial drawings, he didn't close PRS to PRS. Where there was peritoneum, that used to suffice. So they used to save as much of the hernia sac as well. They used to save as much of the peritoneum and the preperitoneal fat, that's the falciform and whatnot, and not force themselves to close PRS to PRS, because even in open surgery that does sometimes come under significant tension and you're worried, and then you're holding on to the patient, asking the anesthetist, please buck nahi hona chahiye, khasna nahi chahiye, patient, don't give reversals and hang on. So rather not introduce all these odd variables. If you have a bridge between the cut edges of the posterectus sheath, just be happy with it. No need to have any stunts.
Yeah, I agree absolutely, because the ARS linea alba and the ARS complex is already intact, so
yeah,
we don't need any more.
Absolutely.
Hi, Eham, can you hear me? Eham?
Yes, doc, I can hear you.
Hi, Eham. I'm Dr. Fanikisha from Hyderabad. Eham, I have two questions. One is, see, when you're doing the TAR, right? Once you divide the posterior rectus sheath and divide the transversalis, and ours is obviously slightly limited experience. Sometimes we get into the proper plane, which, I mean, you showed the yellow line for the peritoneum and the red dotted line for the transversalis fascia, right? Which is a slightly thickish one. And then sometimes we sort of end up going deeper. That means we still have a cover, but it's like a really transparent peritoneum. Probably the transversalis has gone up. So any tips? Right. How do you avoid how do you stay in the right plane once you divide the muscle, transverse abdominis muscle?
Yeah. So when you're doing a top-down approach, don't try to take the entire bulk of the muscle with whatever device you're doing. Say you're doing an open surgery or you're doing it endoscopically. Don't try to dissect off the entire area with a harmonic, because this is what I found. Some of this instrumentation lands, especially the bipolars and the harmonic, they'll end up becoming a little sticky, and they'll end up taking the underlying transversalis fascia along with the muscle. You think you are still extraperitoneal, which is correct in a manner you are, but you're damaging one of the underlying layers. So try to use a hook as much as possible. Another trick is, once you're in the right plane, when you sweep downwards, you have a higher chance of being in the pretransversalis plane.
Okay.
If you sweep upwards, you have a higher chance of being in the preperitoneal plane. The well done TAR, where your pretransversalis is going to have bare muscle fibers with small punctate bleeding all over. Suppose the situation where you said you have paper thin peritoneum underneath and you're a little scared, you can correct yourself once you've opened up that plane by just taking a Maryland, pulling that bit of the fascia off the muscle and just dissecting it with a little bit of the hook, and join your plane as quickly as possible with where you're actually actively dissecting, be it superiorly or inferiorly. So you can correct yourself.
Okay.
And we have the same problem, especially in the minimally invasive procedures.
So in the open, what is the instrumentation you use to divide the transversalis? You hook it up with the Leahy's and then divide with the diathermy, then go on with the peanut. Is that it?
Yeah, that's right. Another additional thing that I have been doing is once I have divided the transversus abdominis for about an inch, I usually apply a right angle clamp to the lateral cut edge of the transversus, and I have someone just lift it up. And with the peanut, then I'll just do downward sweeping. So I am sweeping on the muscle. More likely than not, I sweep the fascia also down. So I'm in the correct plane going forwards. Otherwise, no special instrumentation.
And are you usually leaving drains in the thing after the TAR, bilateral TAR and all that?
Okay, so now this is we are having this massive discussion about drains and retromuscular repairs. I'm pretty sure Dr. Amana will be able to give more insight than I do, but I'll tell you what I do in my practice is minimally invasive patients don't get a drain unless I'm suspecting there's a problem, which invariably has not happened so far. So I don't put drains into minimally invasive patients.
Okay.
If I had a very large defect that has come under significant tension, if I feel like the patient is at a higher chance of abdominal hypertension or ACS, and if the patient is having any pre-existing respiratory pathology that I'm also a little worried about, I'll put in a retromuscular drain. The reason for that is all of the lipolysis that comes in after a bilateral TAR, the small amount of hemorrhage, that's going to collect deep to your anterior fascia, and that can later precipitate or worsen abdominal hypertension or ACS or whatever else. So just in my head, when it's a complex case and when the patient has a high chance of all of these complications, I would put in a retromuscular drain. If I'm talking about a bilateral TAR for the straightforward hernia, easy, no issues, mesh went in aram se, defect closed easily, patient is young, I would not put in drains. But again, we all have very limited experience
Absolutely.
in this area, and our practice is evolving. So over the course of the last year and a half, 2 years that I've been doing this, I have gradually started using drains less frequently. But if there is some evidence that comes out that says, it's better to put in drains, I would put in a drain.
In our ETEP-RX experience, lab ETEP-RX experience, again, we've been doing it for the past 1 year only. We've had around 3-4 patients with post-operative hematomas and all coming up. So maybe it's to do with the technique as it improves. But as of now, we're back to putting suction drains in the pre-peritoneal space in our experience. Thanks, yeah.
Thank you so much for the question. So we have, I'm sorry, who? Hello?
Hello, I'm Dr. Varun Raju from Hyderabad.
Hey, Doc, how are you doing?
Yeah, I'm doing well. So the thing is, if there is a previous history of drains putting there,
yeah,
for other reasons like
prior surgery.
Yeah, prior surgeries with drains are there, and drains are going through the peritoneum, and while you are separating the peritoneum, there may be a piecemeal kind. I mean, there are multiple openings at that area. All the openings, they are going to be closed, or they are going to be just leave like that?
So I would close every opening in the posterior complex, even if it's really small. Take a fine PDS suture 3/0 or 4/0 and just take a figure of 8 and take it off. You raised a very important point. So when you're doing the incisional hernias, mark out all of the prior incisions, and that includes stoma sites, drain sites, because invariably you're going to have some fudging of the planes in the vicinity of the drains. So you may have, this makhan dissection that's going on from top to bottom and suddenly hit this roadblock, and you think you can just power through it, and you'll have a big defect in the peritoneum if you fail to recognize that there was a drain at that site earlier. So what you actually need to do is slow down, try to dissect on either side of the drain site and go behind it. Once you go behind it, you have the sort of tent that lifts up, and then you can divide that area or dissect it and get it down. But these are just steps to reduce the size of the buttonholes that you have. But every buttonhole will be closed, no exceptions.
And one more small question. Just like a tap, the tap for incisional hernias. So the thing is here also, from person to person, the peritoneum is unpredictable. Sometimes it comes very easily, and sometimes it is very difficult, very thin. So the same thing, would that be applied for the TAR also? Because we cannot predict the thickness of the peritoneum here also.
Thinner patients, more difficult to get into planes, easier to buttonhole. Heftier patients, easier to get into planes, more fat, open up more easily, more violations of the abdominal wall, more difficult to get into these planes. you do have difficulty, but just as we discussed earlier, try to stay pre-transversalis and not pre-peritoneal.
Yeah.
So without getting into too many details, I can tell you I am more in favor of a top-down TAR than a bottom-up TAR, because anatomically, when you're doing a bottom-up TAR, you can't start pre-transversalis. You always start pre-peritoneal. And if you don't transition to the pre-transversalis plane somewhere in the middle of the abdomen, you will stay pre-peritoneal throughout. So suddenly you're dissecting on the diaphragm and you're still pre-peritoneal, and the entire thing starts tearing. And that is a very sort of demotivating complication that you have intra, because it takes ages to suture those holes. And the more you try to suture them, the wider they become. Very, very difficult. So top down, try to stay pre-transversalis, especially in complex cases. You can transition between the planes. Just remember to connect all of the planes at the end.
Excellent, man. Excellent. Thank you so much.
Yeah, most welcome. So we have this very nice question. What is your view on unilateral TARs? Do we always have to do a bilateral TAR? Does the unilateral TAR cause problems because of unopposed muscle action on the contralateral side? I don't really think it's unopposed traction, right? Because let me just, does anybody else also want to take this? I don't know if Ravana is still on the, Deepak's there. All right. So the bulk, you are dividing the medial most insertion of the transversus abdominis, but we are not peeling it off the internal oblique, right? So I, in my head, still think that the transversus abdominis does retain some of its action on the abdominal wall as a result. I'm just going to try to pull up some pictures for you guys of the end point of a TAR, just to hammer home the point. If you can just give me one moment. All right, this one sec. Sharing screen. Okay, so can you guys all appreciate this bottom picture? So you have the mesh which is laid down after doing a bilateral TAR. You can see the medial most insertion and the muscle has been taken away, but the large majority of the muscle is still in contact with the rest of the abdominal wall. So I have done CT scans of patients a year and a half after they've undergone TAR, and contrary to what people say, this muscle does not undergo any sort of atrophy. And I don't think there is any sort of functional loss. Say the patient has a stoma site that is really close to the semilunar line, and you have to do a TAR on that side so that you can get lateral overlap. Would you still want to do a bilateral TAR in this small hernia about 5 centimeters wide, just because you've done a TAR on one side? I don't think that makes any sense at all. So doing a unilateral TAR in certain situations, like an eccentrically placed hernia, a lateral hernia, or when you're not able to get decent enough overlap, or sometimes, as we discussed, when the PRS is under some stress or tension in drop, and this is just me eyeballing it and getting a feel for the fascia. A unilateral TAR is, I think, safe in the right hands. If you're not comfortable with doing a restricted unilateral TAR, and if you're not comfortable with the planes, rather just leave it, or get someone to do the case with you at that time to familiarize you better with the planes that you want to be in. Because you don't want to land up with bigger complications over and above a reef stopa, like massive buttonholes or a semilunar line injury or denervation. These are big issues that lead to complex problems remotely a few months to a few years down the line. So don't do any of that. But a unilateral TAR in experienced hands is safe. I personally don't feel it leads to any functional issues.
Yeah, I agree with you, Eham. And because the ARS linea alba and the ARS complex is intact, just dividing the PRS on one side would in no way pull the linea alba to one side. Yeah, because the ARS sheath is intact.
Yeah, that's
the
right.
Complex is intact. Yeah.
All right.
I'll ask you a question. What is the maximum diameter of a incisional hernia defect that you would like? I mean, that most surgeons would be comfortable doing a E-tap TAR. I mean, beyond which you would not like to go in endoscopically. The maximum diameter of the defect.
My upper limit so far has been 12 centimeters. Bilateral TAR. But I'll tell you, despite all of the inherent advantages of MIS, there is some value in performing a good open procedure in a patient who already has an incision previously, because most of these guys come with very ugly scars that would do well with some sort of scar revision that I can offer at the time of open surgery itself. And an open TAR, bilateral or unilateral, is much faster in my hands compared to an ETEP. When a patient has a large primary hernia or an incisional hernia at an odd site, which otherwise is not cosmetically too bad, ETEP is a good, robust option. But I wouldn't apply ETEP ruthlessly across all my cases. I have personally, like 11, 12 centimeters has been the upper limit so far. Beyond that, I have not even attempted it. My open TAR highest defect I've done is about 22, 23 centimeters with loss of domain.
Okay. Is there an upper limit for like a general upper limit for an open TAR? I'm not asking your experience, but a general upper limit for an open TAR.
There's technically no upper limit for any of these procedures, right? Because you apply the procedure, you see how well you can bring the linea alba together. Invariably, there are going to be cases where you can't do it. I've had patients with PPP where I had to bridge the defect. I've had certain other cases with Botox plus PPP, which still didn't suffice to get the abdominal wall back together. I wouldn't count that as a failure. A good sublay mesh, even with a bridging repair with a well-chosen mesh, still offers good outcomes for these cases. And I've had patients following up with bridge repairs. The only thing I explain to them is they're always going to seem like this area of weakness in the area, in the vicinity of the bridging. But the defects aren't enlarging in size. Their muscles aren't atrophying. They have less pain. They are mobile. They have joint back work. So a bridging repair is definitely not a failure. So as such, no upper limit to how large a defect you can tackle. But the Americans, I'll tell you, they involve a lot of plastic surgeons in massive defects, especially in post-traumatic cases. They do a lot of free flaps in those sort of settings. So maybe in that clinical scenario, there would be like this upper limit before which you get a person to come in to do a flap for you. All right. How would you? I'm sorry, I just lost the patient. Sorry, chat. Okay. How do you approach a patient with a linea semilunaris disruption hernia? Oof. Painful, right? So depends on how large or how small it is. And first, I'd like to see what's happening with the mesh inside. Also, after TAR, you are not expecting a lot of intraperitoneal adhesion. So if I can put in a lateral port after optical entry and see how large the defect is, how bad the adhesions are, perhaps do an IPOM plus. If nothing else is helping, you can attempt a preperitoneal repair in that vicinity of the disruption, be it open or endoscopic, but that's going to be challenging. And remember, when everything else fails, there is an Andre repair. That's a good enough option for you. So yeah, I've not done linea semilunaris post-TAR disruptions, but I've done a few of these open. And in open, what I do is I start with a TAR very high up. And I get into the lateral pretransversalis plane and I make my way across the area, almost hug the defect and bring it towards me, and then tackle it. Abhijita sent me a message, views on scola and divarication. Are we going there? Possibly an entire talk a little later. Yeah, scola is a decent enough option for divarication. There's no doubt about it, especially in a patient without an incisional hernia with it. Any word on fixation or mesh in TAR and epigastric region manipulation? I don't know. Abhijit, you want to clarify as to what epigastric region manipulation is? I didn't quite get you. Pants crotch stuff. Okay, so the pants crotch maneuver, please don't get any weird ideas, is basically the surgical step where we use our two fingers like pants to be on either side of fascia. So invariably what you're holding between your two fingers is fascia and only fascia, and you'll end up dividing that. The pants crotch maneuver is super higher up in the abdomen when you want to divide the medial edge of the PRS, or when you're finishing off with the medialization of the TAR towards the central tendon of the diaphragm. These are more technical things I think that we can talk about in greater detail a little later. But I don't like fixing meshes in tar, especially with transfacials. I would avoid them as much as possible. My standard fixation of the inferior mesh, which once again, I can show you guys. Just give me one moment. Kind of losing some pictures. All right, sorry about that. I'm gonna have to hunt for it. So invariably what it is it is this oblong square. The inferior corner of the square is tucked into the Redzius space, and I secure that corner to the Cooper's ligaments on either side with proline 2O, so that there is no chance of an inferior recurrence at all. That corner is just tucked in really well. The inferior edges on either side actually hug the psoas as they go across the visceral sac, and the topmost corner is just left free. If I am putting in another mesh on top of this to cover the epigastric region and to go onto the diaphragm under the costal margin, I classically do not fix this mesh. I'll just let it be because there's no place for it to go. It doesn't make sense. When I'm bridging a defect, I take sutures of the superficial mesh to the defect edges. That's my way of stabilizing the defect to ensure that it doesn't move apart post-operatively. But there's no great science to this. This is just something that we've been feeling, and I have learned from Dr. Punjani and Dr. Ramanna. And to me, it's quite logical.
Hi, Eham. This is Ashwin. Wonderful.
Hey, Ashwin. Thanks so much. How are you doing, man?
Good. So, how's the new kid? And you all comfortable, safe?
Yeah, perfect timing, right? I get to spend a lot of time with her now.
Yeah, perfect. So, my doubt is with regards to the mesh size, what do you generally use as a principle? Is it like a defect centimeter overlap, or is it the area ratio?
I just start with the 30 by 30 mesh. You're talking about open tars or ETEP, like?
No, I just wanted to start from, medium hernias to bigger ones. So ETEP.
Okay. So all of the few recurrences that we have heard about or seen in retromuscular repairs have been because the dissection was slightly inadequate, or more commonly, a smaller mesh was put into a widely dissected space. There was this one case that was being discussed on the AWR Facebook page a few months ago, I think, where an ETEP primary umbilical hernia repair was done, but they had put in only a 15 by 15 mesh, whereas the size of the space is all going to be rectangular, right? Putting in a small square mesh in that space doesn't make sense. So if you have a widely dissected space and a small mesh that's not filling the entire space, I think that's where migration comes in, and you have odd recurrences from the edges of the mesh all over. So when I'm doing any of these surgeries, be it minimally invasive or open, my aim is the dissected space has to be full. I always start with the 30 by 30 mesh. I don't try to suture or quilt meshes together. Never have, and I don't think that follows surgical principle. If you could give me a 50 by 50 mesh to start, I would be happier than using two 30 by 30 meshes. Because I think a mesh interaction and that overlap can also be the cause of patient discomfort, and you're putting in 2 layers of uncoated prosthesis, which perhaps would not tolerate an infection well. Maybe the meshes would slide on one another. We are not really too sure. So the Mudded group actually uses a 50 by 50 mesh to begin, and I think one of the companies has come up with a 45 by 45 centimeter mesh in India just about 4 months ago, but I have not personally used it. But given an opportunity, I would put in a big mesh. Try to put in fewer number of meshes, so long as one large mesh is filling up the space.
So in ETEP, would I be right if I said any defect beyond 5 or say 6 centimeters, you probably will have to add a tar, otherwise your mesh size would not be adequate when we talk about the width?
6 to 8 centimeters, I completely agree with you.
Because the problem is when it's say like 8 centimeter defect, the average width of the rectus we know is around 7 centimeters on one side. So that would be probably a 14 centimeter width we get.
That's right.
7 or 8 centimeter, you're trying to give a overlap of 5 centimeters on either side. Then you need a space of 17 centimeters, right?
Yeah. So fortunately for us, the middle-aged female population that comes to me has wide spaces, retroactive spaces. The abdominal wall is just stretched out as a result of prior pregnancy. So on an average, the female retroactive space in total in my series is about 18 to 20. But I am a little fortunate that way. But in a narrow patient, and especially in male patients, you are going to have to add a TAR on one side if you're doing an ETEP. I'll give you one personal example of mine. I had a 4.5 centimeter defect in a patient who had a recurrent ventral hernia. While dropping everything down and trying to debride some part of the mesh and taking down the adhesions, we ended up losing some part of the posterior sheath. Now suddenly this entire thing is coming under tension. And I was a little scared the thing will give way and I have an interparietal herniation. So I added a TAR on one side. I use my discretion. But when you talk about what it looks like in my data set, it looks like a unilateral TAR for a 4.5 centimeter hernia, which a lot of people would frown upon. But I know in that clinical scenario, it made sense. So we can't stick to absolutes. There is some amount of eyeballing that's going to be involved in these cases. And definitely in ETEP compared to open, there is a lesser threshold or a lower threshold for adding a TAR.
See, my theoretical doubt in these patients is, even though you add a TAR, the overlap on one side is being increased, whereas on the other side, it's not going to be increased. So still, you might be stuck with the overlap of, say, less than 5 centimeters or 5 centimeters. So
if we are talking only about a wide midline hernia and we are worried about overlap, then I get your point. Might as well just do a bilateral TAR. It'll add 20 minutes to your procedure time.
Thanks. And is there like any preset pressure settings which you feel comfortable whenever you do eat it? Because it is kind of subjective, and a lot of the times we feel the tension might be more, and we are more inclined to add a partial TAR or a full TAR or something like that.
Yeah, I agree with that. So my pressures all through dissection are 15, 14, depends on what's happening that day, and depends on who's setting the insufflator for me. But 15 to it's like 14 or 15 is fine. If I have pneumo, then I'll drop my pressures or flow rate initially just to finish off my dissection as quickly as possible. Maybe put in another pot quick. And when I'm doing suturing of the anterior defect, I'll try to drop my pressures as low as I can while still being comfortable. So in certain patients, that's meant 6 millimeters of mercury was comfortable. In certain other patients, I've not been able to suture even at 10. So it depends on that day, how that patient is behaving, what sort of defect it is, what size of needles you have on your barbed sutures. But I try to get the pressure as low as possible. Like if I'm comfortable, I'll ask people to drop it by 1 or 2 points just to see if I can manage with slightly lower temperatures, because suturing under a high pressure of insufflation is very, very counterproductive. I have had the pleasure of doing a couple of cases where we had midline hernias plus lateral hernias. We did an entirely midline ETP dissection, and we did some part of the procedure hybrid. And when we are doing the procedure hybrid, I kind of put my fingers in and felt what my barbed sutures felt like. And I'll tell you, no matter what people say, I genuinely don't feel the suture line under insufflation using barbed sutures is as secure as what we get in open surgery. It seems a little lax, and that scared me when I palpated the suture line myself. And it wasn't because of any technical issue or the suture was bad. It's just physics, right? If you are pulling the fascia apart with carbon dioxide in surgery, and if you're trying to suture, you're never absolutely going to be able to get a snug, secure suture line. You're just kind of hoping that nature does its job very well, and that your mesh posteriorly forms a nice bridge over a period of time if you're using absorbable sutures. So yeah, insufflation with suturing is definitely a concern. Get it down as low as you can. That's all I will say. I won't say there's a magic figure, but just get it down as much as you can. It will definitely help.
Thanks a lot, Eham.
Most welcome, man. All right. Top region TAR differentiating from diaphragm, and how do you... Okay, so I'll take the top region TAR differentiating from diaphragm, and I'll just say Dr. Amana has a wonderful video of the same step. I think it'll be nice if you view that, because he's able to do a wonderful job. The only thing I'll say is, when you're dissecting on the diaphragm, don't make an iatrogenic Morgagni hernia. So remember the namaste. So if the TAR's insertion is forming this namaste sign, it means that your uh, TAR release, the muscle division, also has to form a namaste sign. So the TAR on one side is going to be meeting the TAR on the other side, somewhere in the epigastrium, in the vicinity of the falciform. If you don't do that, and if you just do the division straight up, you will invariably divide the diaphragmatic fibers, which intertwine with the fibers of the transversus abdominis that high up. And you'll end up with a defect that you now need to close and ensure that you put a mesh overlapping that defect. Little challenging, better to see this in person a few times before you try to attempt it yourself, I think, because it's a risky thing to do the diaphragmatic dissection. How do you manage an unfortunate post-op infection in the retrorectus space after an ETAP repair? Put in a needle, get a sample out, culture sensitivity of the pus, and give antibiotics according to that. Give the patient a binder, and drain any collection if it's there. And of course, like, do a CT scan, figure out what's going wrong. Is the posterior fascia intact? Is there something else that's messed about? Has the fascia seem to be sloughing off, or is there some bowel stuck over there? Rule out anything else that will require a surgical intervention immediately. Wait, hope for the best, and a very important part of the protocol is pray, because you're not going to be doing much else. Most of these infections are going to be managed conservatively, perhaps at best with an interventional radiologist sticking in a drain. And yeah, most of these cases do settle. That's the one great advantage of retromuscular repairs compared to an onlay. So yeah. And I think that's about it. One more question. During an ETAP RS for primary umbilical hernia, do we need to suture the whole linea alba? No. So if you have a healthy linea alba on either side of the defect, there's no divarication, there's no reason for you to suture everything. If you have an associated divarication, then close the hernia defect first, and then buttress the entire thing with a separate suture. So you're taking care of the divarication along with the hernia defect. But if the linea alba is appearing to be normal, less than 2 centimeters wide, don't do anything. There's absolutely no need. You'll end up causing a lot more damage and needlessly giving the patient post-op pain. So I think if there are no more questions, we'll call it a day. Thank you so much, guys, for coming in. And next, I think over the weekend, we're going to be discussing energy sources in surgery. That's going to be an interesting talk. I'll share the links with everyone. Thank you so much. Until next time.
Yeah, thanks, Eham. Great talk.
Thanks so much. Bye-bye.
Enjoyed it. Bye-bye.